You're listening to the Pre-Hospital Care podcast on the Medics Academy network.
Today we are speaking around REBOA, looking at the role of REBOA in deep shock. So traditionally it's been reviewed as haemorrhage control, inflate fully, occlude the aorta and stop the bleeding. But in profound shock, bleeding is only part of the problem. Coronary perfusion depends on proximal aortic diastolic pressure. But if the heart itself is not being perfused, everything else we do, including fluids, blood, vasopressors, is working against the clock. So today we're joined by Dr. Jon Barratt. He is a consultant in emergency medicine and pre-hospital emergency medicine with the British Army and with the NHS. He's really the driving force behind the SPEAR program, which is a resuscitation course built around ultrasound-guided arterial access and targeted endpoints for patients in deep shock. Jon was also the principal investigator for the aortic arrest trial, which explored the fundamental use of REBOA to augment coronary perfusion during out-of-hospital cardiac arrest. Joining us also is Hutch. Hutch is the exsanguination specialist for London's Air Ambulance. He brings his own operational and critical care perspective to the conversation. He's really going to also just help us unpack how this technique translates from theory and trial data to real-world pre-hospital practice. So in the episode, we're really going to explore how REBOA is moving beyond plug the leak to really how it's integrated as a tool for deliberate physiologic support in profound shock. Welcome to the podcast, Jon and Hutch.
Thank you.
Just as we start, actually, if I could just come to you first, actually, and really just look at getting you to describe really just the reoccurring light bulb moment, if that's okay, when clinicians sort of stop seeing REBOA purely as a hemorrhage control device and really shift that thinking to how it can be used differently within resuscitation. Thanks,
Owen. Yeah, that's a really good question to open with. So I think for a number of years, I've been working with REBOA for a while. We've considered zone 1 REBOA as akin to doing a resuscitative thoracotomy and applying distal aortic control to prevent further blood loss. And actually, increasingly, we realise that doesn't particularly do always what we expect it to do, and secondly, when we've used REBOA for hemorrhage control, we can see that from the UK REBOA trial. We've been particularly poor at identifying patients that are in life-threatening bleeding states, and also patients have been getting it exceptionally late. And actually, REBOA does provide hemorrhage control. There's no doubt about that. But I think part of the issue that we've understood now is that we're somewhat limited in its application if it's purely used entirely as a hemorrhage control device. And actually, its role in supporting the proximal physiology, and we'll come on and talk about why that's important, actually means that you can deliver so much more than just purely the equivalent of opening the chest and putting a hand on the aorta.
To your point, Jon, I think bleeding, and you've spoken openly about this, is only part of the problem. And maybe if we could just do a deep dive really into proximal aortic diastolic pressure and essentially why coronary perfusion is so often overlooked during early resuscitation.
Yes, a lot of this overlaps with the work that we've been undertaking actually in patients in medical cardiac arrest, where clearly coronary perfusion is crucially important. And what we realised in medical cardiac arrest was that often we were looking at markers of perfusion, whether that was end-tidal CO2 or the presence of pulsatility, and all of that was telling us about the systolic function, and none of it was telling us about the diastolic function. And in the context of medical cardiac arrest, the systolic function associates with the compression phase of CPR, and the diastolic, the decompression phase. But what's really important to understand is that the coronary perfusion only occurs during the diastolic phase, whether that's in cardiac arrest or with an intact circulation. And in certain patients, in particular those with significant aortic injury, they have significant diastolic dysfunction. Coronary perfusion is a function of diastolic blood pressure minus the left ventricular end diastolic pressure. And this is a crucial equation to understand if you really want to understand coronary perfusion at the physiological level. And I think you're right, it's been overlooked for a considerable amount of time because primarily it's not been accessible information. But with the increasing use of invasive blood pressure monitoring, we can actually measure the diastolic blood pressure and then estimate what the coronary perfusion is. And increasingly what we're seeing is in patients with significant aortic injury that their diastolic blood pressure falls dramatically low. And the effect on that is then that the coronary perfusion becomes impaired. And what happens is these patients may survive the initial insult, so they get for some form of hemorrhage control. But what happens is day 2, day 3, they're in retractable cardiogenic shock and simply can't recover because during that period, that prolonged period of cardiac malperfusion, it renders it in an unrecoverable state. So actually, if we can support the proximal aortic diastolic blood pressure and maintain coronary perfusion during that shock state, we're actually protecting the heart as well as preventing bleeding.
Yeah, absolutely. And to your point, John, it really is around getting out of that binary mindset and maybe opening your mindset up to the different possibilities within perfusion, but also to your point as well, not negating the diastolic blood pressure as a means and really the main root cause of cardiac perfusion, really. And if I could really get you to maybe speak to and unpack just really getting out of that binary mindset and you know, it's not an either or, so inflate the balloon or don't inflate the balloon, but really, I guess in a way, a lot more nuance than that. Could I get you to speak to that?
Yeah, definitely. So I think the inflate fully or not at all analogy comes from when we used to say, well, REBOA, it's akin to the resuscitive thoracotomy and proximal aortic control. So in that circumstance, you put your hand on the aorta, you can't really titrate how much force that you apply. You're planning just to completely occlude the aorta. And certainly with the early generation balloon occlusion devices, that was kind of all you could really achieve. So the balloon would be inflated and you would see the proximal blood pressure increase and the distal blood pressure disappear because you've achieved full occlusion. The challenge has been that then to achieve any partial occlusion, and we'll talk about why that's important later, has been technically challenging because of the type of devices on the market. And actually, what increasingly we're teaching is rather than having a technique of based on occlusion or the volume of occlusion or whether you've got full or partial, is actually titrate to the physiology that you're seeing, and in particular the pressure above the balloon, and in particular the diastolic. So, typically most of our resuscitation protocols have strongly trended across to the systolic blood pressure. Most of the blood transfusion targets, etc., have all been based around systolic blood pressure or cerebration, but actually starting to understand that there's more information available to you and utilizing all of that information to give you the best sort of best resuscitation strategy, I think is much more nuanced. Hence why we're trying to say this isn't a binary sort of decision.
Yeah, indeed. No, indeed. And actually it's encouraging to see, and Hutch, I think you'll have a view on this, is that the London's advanced paramedic group are starting to do invasive blood pressure monitoring, and to your point around getting a lot more specific physiological readings that you can then titrate therapy to rather than binary cutoffs is absolutely where we want to be. But Hutch, could I get you to really speak to and come in and just talk about really how clinicians should practically think about the balance between proximal and distal aortic pressures when REBOA is in place, and also in a way why it matters that we balance this so much?
I think the first important cognitive step to understand why that matters so much is to understand what John has just been talking about. And I like to contextualize that personally by comparing stopping bleeding and delivering someone alive to hospital that then goes on to die from heart failure, multi-organ failure, etc., versus slowing bleeding, i.e. more bleeding is happening than if you stopped it, but delivering someone alive to hospital with less myocardial injury, with less end organ perfusion deficit, with less metabolic debt, who then goes on, ideally, not to have heart failure and subsequent multi-organ failure and death. So there's a difference, I think, between measuring success as survival to hospital versus measuring success as delivering someone to hospital in the most survivable condition possible, not just alive. And I think when aortic occlusion is a tool on the table to achieve that survivability, measuring it and understanding it is vital to ensure that you're delivering the right dose of aortic occlusion to promote flow to heart and brain, which I think are the target organs for resuscitation. And no one's ever been able to tell me I'm wrong about that yet, because we don't sort of preferentially resuscitate liver, kidneys, and bowels. To promote flow to target organs, to promote diastolic pressure, to ensure that we're promoting flow to the heart, whilst minimizing the impact of the intervention. So the blunt instrument, you just occlude the aorta, you cross-clamp it via a thoracotomy, or you put REBOA up, completely occlude it. You think all bleeding stops, it actually doesn't. You promote a lot of flow, maybe too much to the brain. You promote a lot of flow to the heart, but at an unsurvivable cost, whereby the liver is in an irretrievable condition, the bowel is in an irretrievable condition. So to balance that cost and to deliver a patient that is not just alive and clinging on, but alive and in the optimally survivable condition, it's essential to be able to measure and be able to balance what we currently measure, which is pressure.
So, John, I'll come back to you actually, and just really, in a way, everything that Hutch has just said there, really around that fine balance. Could I get you to speak to really that training mindset, and I guess a shift in mindset, really, bringing candidates along on that journey to make sense of partial occlusion during training? Because actually, I actually believe if a lot of candidates hear exactly what Hutch just said, it absolutely makes sense to trainees.
Yeah, absolutely. I think this has been crucial when we've been teaching this for the in terms of endovascular resuscitation for medical cardiac arrest as well as for trauma, is actually the underlying foundations in terms of the physiology is often poorly understood. So you absolutely need to cover off the physiology first in order to bring people along on the journey, rather than just focusing on the practical skill. The practical skill of doing it is predominantly based around the endovascular access, femoral access. That's a skill we can train people from, people that have had some experience, people that have had zero experience, people that have got extensive experience. We can train that, but actually the teaching comes in actually understanding the physiology and why we're doing what we're doing, and sort of as Hutch described, explaining why that focus on perfusion to the heart and brain is so vital. As soon as you explain that, people go, yeah, of course, right, yeah, absolutely. But if we've not been thinking in those terms, and it's just been very much the training's been focused on the practical skill delivery, then you miss the supporting physiology that is really crucial. So the whole concept of chronic perfusion, I think, is vital here. Going forward to that, I suppose, in terms of actually training the technique, I think being able to demonstrate with some form of trainer how the balloon occlusion actually behaves. It's remarkable when you use proximal and distal pressure monitoring to see how, even with almost a balloon that appears fully inflated, you can still have partial occlusion. And the way the different types of balloons on the market behave in different states of volume, I think is really, really helpful. Whether that's on an animal model or on a simulator. The other thing I would say in terms of training is it's vital to also be able to train with the actual monitoring equipment that you're going to use operationally, and understand, just from a practical perspective, how do you get two pressure traces? How do they display on the monitoring system that you'd use? And being able to set that up in a slick fashion, I think, is really, really important, because the last thing you want in this critical situation is a load of monitoring faff trying to get the pressure traces set up and the transducers flushed through and all that sort of thing. So that needs to be slick and drilled.
So Hutch, I'm just going to come back to you actually and just ask really around how pre-respiratory clinicians should be thinking about distal ischemia whilst actively supporting proximal physiology. You mentioned the concept of metabolic debt below the balloon. Could I just get you to really unpack that?
I think this is probably the key reason why so many people have so much skepticism about the technique. And it's not unfounded, because the technique is a fatal technique if used inappropriately, right? If you just put high zone 1 aortic occlusion in completely and leave it and think, I've stopped bleeding, then you are causing a fatal metabolic injury to everything that is below that balloon. Irrecoverable ischemic liver injury, dialysis dependent kidney failure, ischemic bowel, limbs that are going to need amputation. It's totally unacceptable. And so in anyone that is intending to use aortic occlusion, it's so important to be really cognizant of that and not be in any way blasé about it. Aortic occlusion is a bad thing to have to do. But if you have to do it in order to generate survival, then you need to do it in a way that A, optimizes what's going on above based on your individualized physiological target. You'll notice that neither of us have spoken about any actual numbers yet, and there's a reason why that is. And B, in a way that minimizes the sequelae of the technique, i.e., prevents as much of that metabolic debt as possible. And I think there are two ways of doing that. The first way to do that is to use complete occlusion as little as possible, if ever. Possibly never, actually. And that's a bit of a step change away from thinking of I'm using this to stop bleeding and towards thinking of it as I'm using this to promote perfusion above the device. Because that allows you to promote flow below the balloon that does minimize the metabolic debt. Now, the so what of that is bleeding is taking place. And so if you think of this tool as a blood-sparing device, you're probably missing the boat a bit. If you've not got enough blood to get the patient to hospital, then what you're sort of doing by putting zone 1 occlusion in is saying, well, I'll get half of the patient to hospital and I'll just accept that the other patient's going to die. And that's not really a sustainable option either. So you have to allow bleeding to happen, because without bleeding happening below the balloon, perfusion isn't happening either, and you're delivering an unsurvivable metabolic injury. So having enough blood and being prepared to aggressively transfuse rather than occlude more is an important way to be able to minimize that metabolic debt. And the other one is time. This injury is a time-dependent injury, like metabolic injury is a time-dependent injury. And ongoing hemorrhage is also a time-dependent injury. And both of those things contribute to worsening of shock, worsening of inflammatory activation, worsening prospect of heart failure and multi-organ failure, and therefore death. So time is probably the biggest of all of this. And so many people are a bit against this technique because they think, oh, it's very time consuming. So we've tried to find out how time consuming it actually is. And we've done some little time trials here. The quickest we've had a crew achieve that access the two transducers zeroed, connected to the device, measuring pressures above and below, and getting occlusion in is 2 minutes and 6 seconds. So it's quick if the access goes straight forward. It's quick, and not always guaranteed. And it's quick if you are trained and practiced and your kit is set up to do it fast. So that's the first thing. But probably even more important than that is you have to give some real deep thought about how and when you integrate this into your care for the patient. Because if you have a bleeding patient that is some distance away from the centre that you need to get them to, and your technique to help get them there in a survivable condition is to occlude the aorta, if you are costing time to that centre by doing that, you're probably costing them survivability. And if you're spending 30 minutes on scene to get your ultrasound going and get your sheath in, and then somehow work out how you do your transducer, then put the kit in, and then you put the device in, and then you think, okay, we should probably leave now, I think your window of opportunity is so narrow to make that work. So time minimization in every patient that needs this is so important. And we are sort of now at the stage in London where we would almost universally consider aortic occlusion to be an en route intervention and not an on-scene intervention at all. The gap between the patient and their destination must be closing in order to minimize the metabolic injury that is a consequence of this technique. So there you go. Allow bleeding to happen and transfuse to let that happen, to allow perfusion to happen, part one. Part two, be quick. And the two ways of being quick are be slick and train hard so you can do this procedure very quickly. It doesn't take as long as you think if you've done that. And move. You've got to move early and you've got to be on the bounce doing this. Practical way of doing that is probably to get your access and then go. Even in extremis, get your wire in, hold onto your wire and then go. And you can put your sheath over the wire while you're on the move.
Yeah, indeed, and that makes absolute sense. And actually moving towards definitive care in that time also makes sense. There has been, and maybe this is a podcast of its own, is trials within the Royal London whereby there's also a lag, and it's prudent, as you say, to look at the lag phases. And there's also a lag sometimes when you wheel the patient through the doors of the emergency department into the resuscitation bay, and just getting the in-hospital resuscitation team to appreciate the injury load, appreciate the nuance, the detail. They've already done a few trials where they're starting to push a lot of that physiological data to the resus bay in a 32 or 40-inch TV screen above the resus bay, so they can start to appreciate the numbers, the nuances of the diastolic pressures or the systolic pressures, and and just really reduce that lag phase of handover, because it often takes 5 or 10 minutes for the team to really get a grip of the patient. And to your point around minimizing the patient journey, the lag phase in the patient journey, I think is super important actually. But just coming to you, Hutch, and just to really ask from a physiological perspective, just how partial REBOA helps mitigate myocardial injury compared to full occlusion strategies. You've already spoken to this burden really of preventing ischemic bowel or ischemic kidney or liver. But again, I think it's a real mindset shift from full occlusion or no occlusion at all. Could I get you to really speak to, because the translational aspect of this is that this maybe should occur not just in the pre-hospital phase, but maybe across the even in the ED up until definitive either damage control surgery or the OR. Could I get you to speak to really, how these concepts, because it's no use of just doing one version of medicine here, another version of medicine here, then another version here. Could I get you to speak to sort of how that translates up until the knife is in the skin?
Yeah, of course. The first technique to achieve that is also a technique to help narrow that lag phase that you described of when the patient arrives in the ED with, let's say, this device in with REBOA in, and the team that is receiving that patient has to do a lot of work to get up to very high speed in a very short period of time. One of the ways that that's achieved in London is a member of the pre-hospital teams integrates within that trauma team and sort of becomes the REBOA person at the hand of the trauma team leader. Therefore, you never actually leave them, and you continuously share your understanding of the patient's trajectory and progress with the trauma team leader. And as the pre-hospital clinician, you go with the patient to the theatre or to CT scan or to IR or whatever is chosen in order to A, manage the device, but B, really importantly, ensure that everyone is up to speed of where they need to be. What am I doing with this device? What am I achieving with it? And at what cost? And how long has it been in there? So having a person integrate into that team is really important to narrow those lag phases and ensure that the wide range of providers who are all trying their hardest to get up to speed with this really complex thing is as best supported as possible. The second part of your question about how can we use partial occlusion to minimize myocardial injury, this is, I think, comes to when do you select to use it? And I think with the strategy we've been talking about, whereby we're learning ways to do this that minimize the consequence, the metabolic debt, I think we're now learning the patients that we can use this in without causing their legs to have to be amputated and they have to go dialysis dependent for life. Therefore, I think we're about to find out, or perhaps we have found out in some cases already, that we probably have learned to use this too late. And we've learned to use it late because of fear of the consequences. And we've had fear of the consequences quite rightly because we haven't known how to manage those consequences. So now I think we're at a point where we can measure better. We have a new device that is arriving on the market that is deliberately engineered to be able to provide very titratable partial occlusion. We are improving our understanding of metabolic debt and how we can minimize it. I think that means we're at a point now where we can use the device earlier. In the past, it's been a device where you go, all else has failed. I am transfusing as hard as I can. They are becoming bradycardic. Their QRS complex is broadening. They are arresting, if not arrested already. And maybe I've got ROSC, maybe I haven't. Oh, okay, let's try REBOA because all else is lost. And those patients, many of them, will already have significant myocardial injury. So the other cognitive step to this about how do we prevent as much myocardial injury as possible is in identifying patients at risk of myocardial injury. And they are the ones with a probably arterial injury with a high rate of hemorrhage and a quick rate of change, rapid decline in a short period of time post-injury, plus minus measured diastolic hypotension with an invasive line, and going, right from the start, I need to find a way to prioritize myocardial perfusion. And I know I can do that in a way that isn't going to cause unsurvivable distal ischemia. So I think the way to unlock using REBOA as a myocardial protection strategy is to understand when you can use it much earlier than we have done in the past. And it is not all bets are off, the patient is dead without it. The patient might survive without it, but they might survive with really bad heart failure and multi-organ failure. How can we prevent that and use it earlier without causing unsurvivable metabolic consequences to promote myocardial perfusion and prevent heart failure, myocardial injury?
So, like Jon was saying before, Hutch, do you envisage this device really being guided by the numbers? So it absolutely isn't linear. And in a way, we can, maybe the question is, are we doing the utmost? Really, what's the proximal and distal physiology doing right now? And changing that real-time decision-making guided by the numbers to really titrate where that balloon is. Is it almost that real time? So it's almost not a protocol. It's almost a real time decision based or guided on the numbers.
Protocolizing this is impossible to do because the complexity of the patients and their rate of change is so difficult to describe. People try to protocolize it, and there will be protocols that include patients that probably benefit from receiving the technique. But there'll be some that are missed. There'll be some that aren't included because they're too good for the protocol. The protocol might say, you can only use this if the systolic is less than 70. And there'll be some with a systolic of 80 and a diastolic invasive line 25, who I'm sure would benefit from the technique, but any protocol would probably exclude them. So there are protocols, and I think they are important to help introduce techniques into systems and services in a sort of governed, checked, managed, safe way. I think this is an intervention with a degree of complexity that probably outstrips what a protocol can achieve. And the way to use it safely and constructively is with the understanding of the physiology and what you are trying to achieve with it. I think we try to slow but not stop the rate of hemorrhage. We try to deliver a permissible amount of distal flow to prevent irreversible ischemic injury. And we try to promote flow to heart and brain. And numbers whereby those things are not being achieved or are achieved in each individual case are probably different. And so more beneficial things to look at are probably rate of change, as in speed of deterioration, response to transfusion, and how much that response is and how long it lasts for, response to the intervention, as in what happens when I give them some occlusion. Am I giving them enough? Am I giving them too much? And have I put occlusion in the right place? So I think it comes to, rather than any absolute values, which can be protocolized but probably are inaccurate in any given circumstance, I think it comes to rate of change, speed of deterioration, and trajectory in response to treatment. That it's telling you who needs it and telling you whether you've used enough or too little or too much. That's vague, and I'm sorry it's vague, but I think that vagueness is intentional because the intervention is complex and it's high risk. Like I said it right at the start, that the intervention can deliver a fatal ischemic injury. So to use it, it is essential to have like in-depth understanding and a deep respect of that potential ischemic injury in order to be able to use this safely, and protocolizing it probably doesn't do justice to that.
So, John, coming back to yourself and looking at new devices on the market, as we were speaking about before, like REBOA Pro, just allowing this titratable control, could I get you to maybe unpack for us what some of the new and or contemporary responsibilities are now placed on clinicians in terms of monitoring, interpretation and decision making? As such, we're saying, the getting this wrong can constitute irreversible bowel ischemia, which in itself can be fatal, or indeed kidney or liver ischemia. Could I get you to speak to some of these new devices and just really how we should approach? Again, it's hard to protocolize this, as Hush was saying. It's far much more nuanced than that, but there is contemporary decision making to be made. Could I get you to really unpack that?
Yeah, absolutely. I think having delivered lots of training with the sort of, let's say, first, second generation devices, key challenges there were you used to have to memorize set volumes to achieve full occlusion and almost like safety limits, which were there predominantly for that reason, to prevent over distension of the balloon and damage to the aorta, which would clearly be catastrophic. But that would be, we'd always be really focused on that with our learners for predominantly a safety reason. And then the other thing that I always found difficult, and I think made people struggle conceptually to fully understand how to achieve some form of partial occlusion, was that the relationship between the volume in the balloon and the pressure above and below and the flow past the balloon was entirely non-linear. So you would reach a certain volume and suddenly lots of flow would return and the pressures would equilibrize between the pressure above and below, and you sort of have to find like a sweet spot, which I think with training people would start to appreciate and understand, but actually increasingly now with the new device that can be done in a much more controlled fashion. In terms of then responsibilities, I think the key is a much tighter focus on looking at the monitoring for all of the reasons that Hutch has described, and exactly as he said, of moving to a strategy where you may never actually even want to achieve full occlusion really changes the landscape. So like we said right at the very beginning, you have to understand the foundations, you have to understand the physiology of what you're trying to achieve, and you move away from a procedure that's very protocolized, I give this much volume in the balloon and achieve this, to give enough to achieve the physiological effect that you're looking for. And we can't tell you exactly what those numbers need to be. We're not going to say increase the systolic by 20 millimeters of mercury, or no, it's not like that. You need to have a deep enough understanding of the physiology in order to make your own decisions for that patient that's in front of you. I think in terms of going through responsibilities and also a bit of opportunities, what this now does deliver us is an opportunity to potentially have occlusion within the aorta, likely some form of partial occlusion focused on optimizing the proximal physiology for an extended duration of time. And I think that's the newest area of sort of responsibilities and possible threats, is how long is that time? And there's certainly data coming out saying partial occlusion up to 2 hours is potentially achievable with the newer devices, but that has to be considered in the entire patient system. So that's only applicable if you've got you can deliver it at the right time, and the place you're taking the patient to can also manage the effects of 2 hours of partial occlusion. Do you have sufficient blood products to support the circulation during that period? Because as Hutch said, if you're optimizing the proximal physiology, you may not necessarily be stopping all the bleeding. And actually that's probably the right thing to do, but that's only going to work if you've got a way of keeping up with that with those ongoing losses. So I think the decision-making responsibilities therefore become really crucial. Like, is this the right intervention? Is it the right time to do it? And are we doing it for the right reasons? And can the system support us doing it for this patient at this moment in time? Before we start seeing this as like the silver bullet for sort of people with non-compressible hemorrhage at reach from a damage control facility.
Yeah, indeed. No, indeed. And I guess in a way to that point, John and Hutch, I'll bring you in, is really, the temptation is to now say, right, this is airway, breathing, circulation. Every patient with certain types of trauma gets femoral access. So we integrate it, but actually, maybe it is prudent to think in the multi-system trauma patient, maybe this is part of the airway breathing circuit, the big C, or indeed the even the mass hemorrhage control. So even before you get to the airway breathing circulation. But could I get you to speak to really where this, because you mentioned this before, and I think this is powerful. It's an intervention en route, and but actually you can start the intervention at the scene, and maybe the easiest way, because we're all familiar with the big external hemorrhage and then the airway breathing circulation, putting it into an algorithm like that might be helpful for a certain kind of array of patients.
Oh, and I don't know how controversial you want me to be, but I have a view on this, which probably doesn't surprise you, and it is somewhat deviant from traditional protocol. So let's do it. Yeah, airway breathing circulation for bleeding patient is, I think, hilarious, because the problem is hemorrhage, right? If you can see that the problem is hemorrhage, I don't know any airway or breathing intervention that helps with hemorrhage. And traditionally, like the catastrophic hemorrhage in those brackets, or the massive hemorrhage, depending on what March or ABC you choose to use, is solely for external, right? Because that is where we teach people to put the tourniquet or pack and do compressible hemorrhage control techniques. And therefore, by design, we're somewhat blasé about the non-compressible hemorrhage, which is totally backwards, because the non-compressible hemorrhage is the one that we can't do anything about. The compressible one, we treat it first because it's squirting us in the face. The rate of hemorrhage may be even more than that if someone's ripped their liver off the aorta inside, but we can't see it. And so we go, oh, we'll sort that out in C, which is wild. You wouldn't just let someone's arm go while you sort of sort the someone hose from their brachial artery while you sort out the airway and the breathing. So I am somewhat, what's the word? I can't think of it. When you kind of split people down the two, divisive in this. ABC for bleeding patient, access, blood transfusion, chest, which is a complete reversal of airway breathing circulation. But I think it's access, blood transfusion, chest and airway together. And what that lets us do is prioritize resuscitation. Access is big access in big veins, or big drips in arms. Blood transfusion needs to be done all correctly and titrated to the patient's rate of decline and rate of change and rate of response to transfusion. And then aortic occlusion, if you need it, follows straight on after. Don't think it's a tool for when you haven't got blood. I think that makes it unsurvivable. I don't think it's a tool for when you're running out. I think that means you've used it too late. And there's probably myocardial injury that's happened that could be avoided. But I do think that when you know that the patient is bleeding, possibly to a potentially fatal degree, prioritizing management of that bleeding, which may be access, blood transfusion, leave scene, no airway, no breathing, is an important shift to make to narrow that gap. And I think having aortic occlusion in the armory early doors, having access already in and gaining arterial access as a routine part of your package of bleeding patients quickly and safely without spending 20 minutes on scene fiddling around in the groin doing it, is probably how you start to integrate aortic occlusion early doors into these really sick cases as a physiology-guided resuscitation pitch. And not well, I've tried all the stuff, they're still getting loads worse, I'm running out of blood, let's put aortic occlusion in. I think if you're in that situation, the situation is unsurvivable no matter what you do in that context. So perhaps some of the reason that outcome over the years from aortic occlusion is poor is because of the context where people have selected to use it. And if we select to use it in a different context, a faster, leaner, earlier context of targeted proximal physiology and permissive distal flow, that's probably how you change it from a last ditch option. Everything else has failed. Let's try this. You're probably in a failing situation, to one where you are augmenting a very finessed resuscitation.
We've sort of probably underplayed the role of access in all of this. Access is absolutely crucial. So we spent a long time working with the EVTM Society, who's tried to almost change the resuscitation algorithm to putting access before airway, and that's both venous access, as Hutch described, likely a large bore subclavian line or large drips in the proximal peripheries. But femoral arterial access here is your gateway to being able to achieve any of these interventions. And it is difficult. It's not the same as doing it in an operating theatre in an elective surgical case, but it can be trained. Probably something for another podcast. But the whole concept of achieving femoral arterial access in shocked patients, whether that's because they're in cardiac arrest from a medical cause or because they're in hypovolemic shock, I think is really, really important. And it's obviously clearly the gateway to being able to achieve any more advanced endovascular intervention. So shifting that in the algorithm suddenly means that with invasive blood pressure monitoring, we've actually got reliable data to work with. I think we've all been there with non-invasive blood pressure cuffs that either cycle infinitely without giving us any reliable numbers, or even worse, give falsely reassuring or numbers that are sending us completely in the wrong direction and seem unbelievable. So actually having that reliable invasive blood pressure and then actually be able to see what the diastolic is doing in the context of understanding that's crucial in order to maintain chronic perfusion, then that's a real game changer. So seeing arterial access as sort of having two strong elements to it. One is that it clearly gives you the most accurate data as to what's going on in terms of the physiology in the aorta, and then also if you then need to perform an intervention, you've got that option open to you. I think is really, really important. So prioritizing arterial access early in the algorithm, I think, is something that needs to be considered, as Hutch says, way before. In fact, you can't do any advanced airway intervention without some form of access anyway. So and most of these patients, if they do have an airway problem, as you start to resuscitate them, it improves. So I think we could really look to where that fits.
Yeah, absolutely. No, absolutely. And gosh, that is a podcast of its own, because you're just rewriting some of these fundamental integrated mindsets that you're trained so early on within sort of clinical practice, but absolutely there does need to be a paradigm shift. And maybe we'll do another podcast down the road just on that paradigm shift. Absolutely. Hutch, I'll come to you. We're just coming in to land on the conversation. I'm mindful of time. Just a couple more questions. Hutch, one to yourself really would be around, in a way, common pitfalls that you would see when teams maybe first attempt partial REBOA, and how we can maybe navigate these pitfalls through education and simulation to, in a way, better prepare clinicians to avoid failure.
I will offer you three things. The first is that the access is so hard, and there's no way around that. That access is so hard, and if the access is really easy, you've probably chosen the wrong patient, right? They're not bleeding. So, being good at access and taking every opportunity you can to get better at needle, ultrasound, wire, in shocked patients, in cardiac arrest patients, is really so important. So access, and practicing it as much as possible, practicing it on the move, practicing it on the ground, practicing it kneeling with the patient on the trolley bed, all vital. So that's the first pitfall, is access and access site complications. And there is no way around just saying you have to do as much of it as you can. It's hard. The second is the pitfall is thinking that your REBOA is your resuscitation. The REBOA will make a number look better, but it is not your resuscitation. Your resuscitation is your blood transfusion for the bleeding patient, right? The REBOA makes your blood transfusion work and sends your blood transfusion to the right place. So a pitfall is putting the kit in, inflating the device, and going, we're done. That is absolutely not the case. It is blood transfusion that allows you to save the patient above the balloon, and it is blood transfusion that allows you to provide that distal flow and prevent irreversible metabolic debt. So thinking about the device in isolation and going, I've put REBOA in, so I've stopped bleeding and things are better, is absolutely definitely a pitfall. And we have to not think of it as that. We have to think of it as a physiology improvement device that helps your blood transfusion to work. The resuscitation is the blood transfusion. REBOA just sends it to the right place. So that's important. And then the third, specifically regarding partial occlusion, is this harks back to what I said about how complex the intervention is and how difficult it is to protocolize. So current protocol would say you take 0.5 ml out and then you sort of see where your numbers set. And then you maybe take another 0.5 ml out and you see where things sit. And then you maybe take another 0.5 ml out and you see where things sit. It's a nice concept. It's straightforward. It's easy to teach. It's measurable. It doesn't really achieve what partial occlusion needs to do. So the pitfall here is that providing titrated partial occlusion is all-consuming. It is absolutely all-consuming. And in order to do it in a finessed, minimized way that promotes proximal physiology without being at the expense of distal metabolic insult. And by that, I mean, take a patient who's, let's use the same injury as I mentioned earlier. Their liver's been ripped off the IVC and off the aorta. And they are hosing blood into the abdomen at such a rate that they deteriorate to the point of almost bradycardia and wide QRS in the time it takes to change a transfusion bag. That's 30 seconds, right? That's 30 seconds of stopping transfusing and they're piling in and nearly arresting. So your REBOA person needs to have the syringe in their hand constantly. When that blood transfusion runs out and stops, they're going to have to put a bit more occlusion in. And then you put your new bag on, you open it up wide and give it a squeeze, you pump your pressure bag up, things improve, and your balloon needs to come down as things improve to allow bleeding to happen. So this is definitely a pitfall. It is all-consuming to provide constantly titrated partial occlusion, but that is the way to do it, to promote the proximal physiology as best as possible and to minimize the ischemic insult. You need to be constantly trying to get that balloon volume as low as you can possibly get it. Any park and leave is causing additional distal ischemia that's potentially unnecessary. So there you go. Access, thinking that it's occlusion, it's your resuscitation, it's not, it's blood transfusion, and the all-consumingness of providing the lowest dose possible of aortic occlusion are, I think, the three key pitfalls.
Just finally, Jon, I'll come to yourself just as we come into land. If I could just really, this is a tricky question really, but in a way, if I could get you to just think about if you could rewrite how REBOA is taught to pre-hospital clinicians from the ground up, what are some of the core principles you would insist on embedding from, in a way, from day one?
Yeah, cheers, Owen. Actually, giving me a nice chance to reflect on the sort of journey that I've been on with sort of understanding how this device has evolved and also how to teach others to utilize it. And I think, as Hutch has really nicely described, this doesn't neatly fit into a procedure that can be driven by an SOP or a protocol. So moving away from protocolized, you must do 5 insertions of the REBOA on the mannequin, and you need to know what the maximum volumes are, to which is certainly how this was taught previously, to changing completely to you must understand what is happening on a physiological basis to this patient and where this intervention fits within that. And actually looking at how courses that I've been involved in designing and developing have evolved from 1 to 2 to 3 days. What hasn't actually changed is how much time we spend putting the actual devices into mannequins. That stayed the same. What's added around it has either been spending extra time going into deep dives into the physiology. And once you start to explore this, learners really start to appreciate and engage with it and understand it, giving some clinical scenarios where this may be useful and challenging the current sort of conceptual norms around what defines shock states. Again, really, really important when that's paired up with the coronary physiology. The actual procedural skills often just stay the same. And then what you can add on to the final part is broader simulation with all of the kit, exactly how you would do it operationally, using the transducers that you'd use operationally and becoming slick and drilled with it. But yeah, as I say, what doesn't need more time spending on it is the actual procedural bit. It's the stuff that comes before it and the stuff that comes after it, how you integrate it, that's really, really important. So that's what I would, in fact, that's what we are changing in the courses that we're involved in that include REBOA as a component, but it's not a pure, anyone that's advertising a pure REBOA course, I'd be somewhat skeptical about, because there's such a broader concept to be understood around shock states, maintenance of coronary perfusion, and how to integrate it in the broader shock resuscitation.
Listen, that's fantastic. And I think what I'll do is put really in the show notes some of the fantastic LinkedIn posts that you've both been contributing to, because around this BEAR course, because to your point, it's a mindset shift to both of your points. And there's a bigger conversation to be had around training, around paradigm shifts, and around how we approach the shock patient, and maybe far more of a nuanced perspective on the ABC of approaching a shock patient. And actually we will do another podcast if that's okay, because I think it's such a universally known concept that actually it does, the script and the narrative does need to be rewritten, because as you were both saying, seconds equals mortality and morbidity, and that might not just be fundamental mortality, but morbidity of ischemic bowel, ischemic liver, ischemic kidneys, and actually mitigation of all this through changing that mindset, through the early intervention, and actually through that whole chain is a powerful reframer. And I would love to unpack that with you both.
Be great.
It would be great. And I think the things we've been talking about today are pretty much at my limit of understanding. So maybe interpret some of it with caution. Some of it's just like ideas that are in my head that aren't sort of out there for prime time yet. So hopefully like some concepts and some ideas that are sources of reflection. And if there's an opportunity to speak perhaps in a bit more detail or a bit more refinement, then that's probably a good thing to do. Because at the moment, I feel like I've just blown the lid off the box and left it there. So good luck, everyone that's been listening.
You're listening to the Pre-Hospital Care podcast on the Medics Academy Network.